facial nerve palsies are becoming a common entity, especially in this era of increasing road traffic accidents. We have discussed the fracture of temporal bone that can happen along with the skull-base fractures. You might have also noticed facial nerve palsies after a paroidectomy, after some neck dissections, after viral infections, especially herpes zoster infection. And in all these cases, some of them will recover after a time and some of them will not recover. We will need a surgery, or we have to give medications, physiotherapy for a long time. And why this happens? So what is the pathophysiology of facial nerve disorders? To know the pathophysiology of facial nerve disorder, first you should have a clear idea of the sheath or the layers covering the facial nerve. And how many of you know what are the layers covering a peripheral nerve or the cranial nerve, and not only facial nerve? I'll tell you. This is an axon. Okay, this is an axon, and mind you, for the facial nerve there are about 10,000 fibers and nerve fibers, and around 7,000, or out of the 10,000, around 7,000 nerve fibers are going through the facial nerve proper. And facial nerve proper, what is meant for? It is a motor root, and it is going to the muscles of facial expression, right? So around 7,000 fibers are going to the motor root, and the rest, around 3,000 fibers, are going through the sensory root or the nervous intermediates, right? So the axon covered by a myelin sheath from the myelin secreted from the Schwann cells, right? And it is that. And around that there is a covering of endoneurial covering. There is endoneurium. So one axon with its myelin sheath surrounded by a protective connective tissue covering of endoneurium, and then it is called a nerve tubule, right? It is a tubule. It's a tubule. So what is there? One axon. There are axon covered by endoneurium, right? So each of them is called a nerve tubule, and so many tubules are again covered by a protective connective tissue layer, this one, and that is the perineurium. Okay, so outside the endoneurium covering is called a tubule, and so many nerve tubules are covered by a perineurium. And there will be more than one perineurium. In this, each one of this is called a nerve fascicle. It is a fascicle. So nerve tubule, then comes a fascicle. Right? So this is a fascicle. Then so many fascicles like this, they are covered by again a protective connective tissue layer around the nerve. That is this red cell, and that is the epineurium. Okay, nerve sheath, the proper nerve sheath. That is the epineurium. An axon covered by myelin secreted from the Schwann cell, and that is covered by a protective connective tissue layer called the endoneurium, forming a nerve tubule, and so many tubules are bound together by the perineurium, forming a nerve fascicle, and so many nerve fascicles forms the nerve proper, and the final, the outermost nerve sheath is called the epineurium, right? This is the epineurium. So endoneurium, perineurium, and the epineurium. Okay, with the nerve injuries, you have to remember two names. One is Seddon and another one is Sunderland. Seddon and okay, and another one is Sunderland. These two persons described the types of progressive facial nerve injury, right? And according to Seddon, there are three types of progressive facial nerve injury. One is Seddon described it. Okay, one, it is a neuropraxia. What is that? Neuropraxia is that if you give a constant pressure over a nerve, what happens? There is blockage of transmission of nerve impulses. But there is, if you give a pressure here, you give a pressure here for a constant pressure over a short period of time, the transmission of nerve impulses will not happen. You are pinching that, so there won't be any transmission of nerve impulses. And if you release the pressure, what happens? The complete recovery happens. Okay, there is no injury to any part of the nerve, and that is neuropraxia, right? And second one is axonotmesis. What is that? In this axon get injured, right? There is injury to the axon, but endoneurium is preserved. Okay, the axon is divided. In axonotmesis, axon is divided. Endoneurium is preserved. There is no injury to the endoneurium. And the third type is neurotmesis. And what is this? Here, complete division, a complete cut. Now cut is there at this level. So the endoneurium, perineurium and epineurium, everything is divided. So these are the two types of progressive nerve injuries as described by Seddon. Detailed classification of the nerve injury was proposed by Sunderland, and according to him there are 5 types of nerve injuries, and his classification is mainly for the traumatic facial nerve palsy, but in Seddon's classification can be applied in due to all type of nerve injuries, that due to trauma, that due to infections or due to pressure effect by the tumors, everything. And this is Sunderland's classification is a better classification. According to that, there are 5 degrees, and first degree, second, 3, 4 and 5. And Sunderland's type 1 is neuropraxia. Only the there is block to the transmission of nerve impulse, and it is completely reversible. And in type 2, it is injury to the axon, which we can come to axonotmesis. And in type 3, there is injury to the endoneurium also. And in type 4, type 3 plus injury to the perineurium. Okay, here comes a 3, here comes a 4, and in 5 again complete nerve cut, right? So, and recovery from a facial nerve palsy is graded by House Brackmann grading. There is another term you have to grading system. This grading system you have to study, that is House Brackmann. Okay, House and Brackmann's grading system is for the recovery from facial nerve palsy. There are 6 grades. Now I will tell about what happens or what is the pathophysiology of each of the types, each of the degrees of facial palsy according to Sunderland, and we can correlate it with the House Brackmann. Right? First will be the degree of injury. So according to Sunderland's classification, there are 5 degrees of injury, and this will be the pathology of injury. Right? That is what happens along with the all these 5 types, 5 grades. And there are electrophysiological tests used for the facial nerve injuries that we can discuss in after this. So mainly there are 2 types: evoked electromyography (EEMG) and maximum stimulation test. Evoked electromyography and maximum stimulation test. And what is the neurobiology of recovery? What happens along with the recovery? And finally, we can grade the spontaneous recovery according to House and Brackmann. Okay, House and Brackmann grading. First degree. I already told, only there is compression. Okay, so that is equivalent to the neuropraxia, right? What is the pathological injury? There is only compression. Okay, and this is reversible and complete recovery is possible if we are pressing that nerve over a period of time, and if we remove the pressure, the nerve impulses will return back to normal, right? So this, what will be the electrophysiological test? That will be normal, right? And is there any morphological changes? There is no morphological changes. Normal. Okay, there is no morphological changes. And complete recovery happens, maybe it takes a period of 1 to 4 weeks. And what about the House-Brackmann grading? It is grade 1. Okay, there is normal symmetrical function of the facial muscles. Normal function, right? And it is symmetrical also. That is grade. In this second degree injury, it shares features similar to an axonode muscles. What happens there? There is compression. Okay. This is your axon. Right? So there is myelin sheath. Okay, and surrounded by, there is an endoneurium. Okay, so here this compression is persisting, so there is increased intraneural pressure. Okay, so what happens? There is axons are lost. There is loss of axons. If here is an injury, there will be loss of axons from this area. But this endoneural nerve sheath is, tube is remaining intact, right? So what happens here? There is loss of axons. And this endoneurium is intact. So what will happen? These axons will grow into this empty myelin tubes. From here, axons will grow. Okay. Axons will grow into this. It will grow and fuse with this. Right? Because of the endoneural tube is intact from the distal part. This is distal and this is the proximal. So from the distal site of trauma, axons will grow into the neural tube at a rate of 1 millimeter per day. These axons will grow at a rate of 1 millimeters per day. And what happens here actually, if there is immediately after the injury, there is Valerian degeneration. That is, Valerian degeneration happens. Okay, on this side. And what is this Valerian degeneration? What is that? And if there is a trauma to any part of the body, immediately there will be an inflammation. In reaction or an immune reaction to the injury, there will be inflammation. Right? Similar to that, here also there will be a neural inflammation. There will be a cascade of neural and molecular changes that will happen, and actually it is a type of neuroinflammation, and that will happen from the distal segment. Right? That is called Valerian degeneration, and actually this Valerian degeneration will start around 1 to 3 days after an injury. So the electrophysiological test, you will get a change in the electrophysiological test only after 1 to 3 days. Okay, now you will not get a change immediately after sustaining an injury. Right? That is because of the delay in the progression of a Valerian degeneration, and these axons will grow into the empty neural tube at a rate of 1 millimeter per day. Okay, right? This will grow into this. It will grow into this. Right? So that happens here. So what will be the result of an electrophysiological test? 0 to 10% of normal. Okay. Growth of axons. At a rate of 1 millimeter per day. And what is the House Brackmann grading for recovery? It will be grade 2. Right? What is grade 2? There will be slight weakness only in close inspection. സൂക്ഷിച്ചു നോക്കിയാൽ കുറച്ച് ഡിഫക്റ്റ് കിട്ടും. Right? That is slight, will be a very slight weakness seen only on very carefully watching the face. Right? It is barely noticeable. Even then, there will be a minimal amount of muscle weakness. That is grade 2. Okay. Then there is chance of synkinesis. Synkinesis. What is this synkinesis? That I will tell after the pathophysiology of nerve injury. Right? Okay. There are 4 types of problems happen when a nerve regenerates. That I will tell along after this this classification. Right? 3rd degree injury. 3rd degree. What happens there? This intraneural pressure increases. Then what happens? On this thing, there is intraneural, there is a compression. If it is go immediately, that is reversible transmission of nerve impulse. And the pressure stays there for a longer period. This compression causes loss of axons. And if this compression again it increases, what will happen? This endoneural nerve sheath are also damaged. Right? Okay. There is damage to the endoneurium also. Okay, so what happened? Here is damage to axon plus endoneurium. So what will happen in an electrophysiological test? There won't be no response. No response. From here, 3rd, 4th and 5th, there won't be any response to electrophysiological test. Okay. And what is the neurobiology of recovery? There is loss of myelin tubes, isn't it? So what happened? So the new axons have got an opportunity to mix up and split. So what happens here actually? There is an injury to the myelin sheath, right? This part. So the new axons will grow. From here, the new axons, there is no myelin sheath, endoneurium is lost. So this new axons that is coming, what will it do? As there is no endoneural sheath around them, and 2 or 3 are coming. There is no one to control them. So what happened? They will mix up. Instead of going directly to this part, it will come here, it can come here. Right? And also sometime they will split up. One part will go here and the other part will come here. So they are coming, instead of going directly to the cut end, they will split up or sometime they will mix up. So that one nerve tubule will go to another nerve tubule within a fascicle. It will go to different tubules. So the innervation or the final destination or supply will be different, right? So that it will go for a synkinesis. That is the basis of synkinesis. Hope you got the symbol. Actually an axon, 2 axon, and around each one endoneurium forming 2 nerve tubules, right? So what happens here? Endoneurium is lost. So there will be a final covering of perineurium of the fascicle only. So instead of coming and joining with this parent axon, it will go here or it will go to some other axon. Okay, or sometime it will split to one part will go to here and the second part will go to next axon, right? So there will be mixing up or split up of each axon fiber, and that is the basis of synkinesis that I will tell you later, right? So that is what happens there. So there will be loss of, what will be the neurobiology? There will be loss of myelin tubes. Loss of myelin tubes, and there is opportunity. These myelin tubes will come, they mix up with other axons, or they will even split up. So what will be the House Brackmann grading? It will be grading either 3 or 4. What is that? 3 is there will be an obvious weakness, but it is not disfiguring. Right? Obvious weakness will be there, but it is not disfiguring. And in grade 4, what will happen? Obvious weakness and it is disfiguring. In grade 3 is moderate dysfunction. There is a weakness, but it is not disfiguring to the patient. And 4 is moderately severe injury causing weakness which is obvious and disfiguring. Right? These 3 or 4 can happen with the 3rd degree injury. Hope you got it. Fourth degree, there is partial transection. Both this endoneurium as well as the perineurium is cut. There is no cut of the epineurium. Only this perineurium as well as the endoneurium is lost. Okay, so there will be partial transection. Right? So there will be partial transection, and there won't be no response to the electrophysiological test. And what will be the neurobiology? There is axons will be blocked by scarring. Right? There will be scarring in between. Okay. There happens scarring. Chance of scarring is there, and there will be impaired regeneration. Because of the scarring, there will be impaired regeneration occurs, but there will be impaired. Okay. And scarring and impaired regeneration. And what will be the House Brackmann grading? It will be grade 5. What is that? That is severe dysfunction and motion is barely perceptible. Okay, the motion of the muscles will be barely perceptible, that you want looking, you can see a very minimum of movement of the facial muscles, right? That is grade 4, that is severe dysfunction, right? And what happened with the 5th grade? This epineurium is also lost. So there will be a complete transection. The nerve is completely cut. So there will be no response to electrophysiological testing, and actually there won't be any regeneration at all. Okay, in this case, this complete disruption, and there is a scar filled gap will be there. So there will be no regrowth of axon, and also there won't be any reanastomosis of the neuromuscular junction. Okay, axons will not regrow, and also there is no reanastomosis of the neuromuscular junction, right? So no regeneration. And what will be the House-Brackmann grading? Grading will be 6. Okay, total paralysis will be there. There will be no movement, there will be no tone, there is no synkinesis, no contractures, no spasm. That is House-Brackmann grade 6. Once again, I will explain this. This is 5 types of degrees of injury as per Sunderland's classification. And this is House-Brackmann grading for the facial nerve recovery. And with the first degree injury, and there is only compression of the nerve sheath, compression at the level of axons. So the electrophysiological test will be normal, and there will be no change in the morphology. And this House-Brackmann grading will be grade 1. What is grade 1? There is normal function, and it is symmetrical and normal function of the facial muscles, right? Second degree injury, there is loss of axon, but the endoneurium is intact. So there will be distal Valerian degeneration, as the axons will grow into an intact endoneurial sheath. And electrophysiological test will be 0 to 10% of the normal. And actually there is growth of axons will occur at a rate of 1 millimeter per day. And there is a very minimal chance of synkinesis during regeneration. And grading is House-Brackmann grade 2. There is slight weakness, mild dysfunction, that is slight weakness on close inspection, right? And in third degree injury, the axon along with the endoneurium is damaged. So there will be no response to electrophysiological testing, and there is loss of these myelin tubes. And on regeneration, there is chance that they will mix up, and there is also chance of splitting of the growing end. So there will be synkinesis, there will be muscle spasm can also occur. And House-Brackmann grading is 3 or 4. 3 is moderate dysfunction, that is obvious weakness but it is not disfiguring. And 4 is moderately severe dysfunction, there is obvious disfiguring weakness. And in 4th degree of injury, there is partial transection, that is the perineurium is along with endoneurium is damaged. There will be no response to electrophysiological testing. Scarring chance is there, so the regeneration rate will be very slow. And House-Brackmann grading 4, that is severe dysfunction. There is motion of the muscles barely perceptible, barely visible. And the 5th degree injury is a complete transection. There is no response to electrophysiological testing. There is no regeneration of the axon, and there is no reanastomosis at the neuromuscular junction. And House-Brackmann grading is 6, that is total dysfunction. There is no movement, no synkinesis, no contractures, and no spasm. Okay. During the nerve recovery after an injury, there is chance of nerve dysfunction. That is because I already told axon after an injury, the axons will grow in case of second, third and partly in fourth degree of injury. So the axon, if there is a neural tube around that, it will grow into the same neural sheath, same endoneural tube. And if the endoneurium is also damaged, these growing axons, there is chance that the end of the distal growing axon will split or it will mix up with the other axons in the same fascicle. Right? Clear here. This is the distal part, this is the proximal part. If there is an injury here, this growing axon, as there is no endoneural tube around them, this will grow and at the end it will not come to the corresponding cut segment. It can either go to the other nerve tubule or it can split. So this axon, this tubule will come and innervate this tubule. There is any possible rearrangements are possible. Any type of rearrangements are possible. Sometimes they will not synapse. There is no synapses here. See, this axon has gone to this one. Again this is also. So same nerve in the same fascicle, each growing tubule can go and take its own combinations. So this causes an altered function. There are 4 types of altered function. One is a synkinesis. Right? One is synkinesis. That is abnormal synchronization of the movement. And the first one is synkinesis. Another one is crocodile tears. Okay, tendon contraction. Stapedius tendon contraction. And fourth one is facial myokymia. These are the 4 types of altered function of the facial nerve after regeneration. The basic reason I have already told. There is regenerating axons will mix up with the nerve tubules destined to go to another motor unit. So instead of reaching the destination or the required area, the regenerated tubule will go and distribute to other areas. So one is a synkinesis. What is that synkinesis? In synkinesis, there is abnormal synchronization of the movements. If the patient is wrinkling his forehead, along with that, this angle of mouth will droop, or there will be twitching of the muscles of the chin, like that. Or sometime when the patient wrinkles his forehead, his eyes will automatically close. Right? So that can be very much distressing to the patient, and in some cases it will be very mild and go unnoticed. Like when the patient closes his eyes, there will be a minimal twitching of the muscles of the chin. Sometimes it will be very much disfiguring and also distressing. Right? So that is synkinesis. It is an abnormal synchronization of the muscles of facial expression. Okay. And second is a crocodile tears. What is that crocodile tears? That is unilateral lacrimation of the affected side associated with eating. So what will be the cause of that? Think this is a greater petrosal nerve. That is for lacrimation, going for lacrimation, and this has a salivation. Right? The muscles, the nerve root, sensory nerve root coming from the superior salivatory nucleus will split into those going for lacrimation at the as a greater petrosal nerve, and along with the chorda tympani it will go to the submandibular and the sublingual salivary glands, isn't it? So if the lesion happens at or above the level of geniculate ganglion, what will happen? Sometime the fibers going for salivation, instead of reaching the chorda tympani fibers, will go and unite with the fibers going for the lacrimal gland. So when the patient sees the food or eating, instead of the salivary gland stimulation, the lacrimal gland will get stimulated. So there will be lacrimation, right? So this should not be confused with the Frey's syndrome, which is an auriculotemporal nerve syndrome. And what is the Frey's syndrome? That is something happening with the after parotidectomy. That is gestatory sweating. And this gestatory sweating and the crocodile tears are different. And in stapedius tendon contraction, the basic pathology is the same. There will be abnormal communication between the muscles of facial expression with the nerve to stapedius muscle. So along with facial movement, there will be fullness or ringing sensation in the ear. So how can we detect that? It is by doing an impedance audiometry. There will be stapedius muscle contraction. And if it is very much distressing to the patient, what can we do? Just cut the tendon of stapedius, right? What is facial myokymia? It is a very much distressing condition. There will be continuous fibrillary movement of the facial muscles, so that the patient will have an appearance of bag of worms, right? Usually it is associated with the multiple sclerosis and brainstem tumors, right? So facial myokymia, there is continuous fibrillary movement of the facial muscles, usually associated with multiple sclerosis and brainstem tumors. So these are the common injuries or conditions of altered function of the facial nerve after an injury, and that is due to its mixing up of nerve tubules in a nerve fascicle. Okay.